in teams. And there is increasing evidence that failure in teamwork and communication contributes substantially to patient harm. So failure in communication in the operating room results in inefficiency, waste, delay, tension, and procedural error. So team training through simulation has been found to work in fostering good leadership and well-functioning OR teams during a crisis. The current level of evidence supports the use of simulation techniques in the training of anesthesiologists. So simulation training is known to increase self-reported confidence and clinical performance. However, very few studies have been made to link simulation training to improve patient outcomes. The cost of implementing simulation training in anesthesiology must be justified by a demonstrable improvement in patient outcomes, and therefore more studies have to be undertaken. But the potential benefit to patient safety is there, and as the authority in anesthesiology simulation says, we cannot wait for unequivocal proof of the benefit of simulation before embracing it. Simulation has a strong positive impact in healthcare, especially by lowering the risk to actual patients, by providing a method of learning about care processes, and by helping establish a strong culture of teamwork and collaboration within the clinical workspace. So simulation provides anesthesiologists a safe venue for deliberate and intentional practice. Simulation scenarios can be used for orientation to new procedures and exposure to uncommon clinical scenarios. It can accelerate skill acquisition, improve skill retention, and reduce skills decay. And simulation provides advantage of a safe environment for crisis management training and is a lifelong learning strategy to manage uncommonly encountered clinical crises. So with that, I'd like to say thank you.
Okay, we'd like to thank our speakers today. Um, and now I'm going to open the floor for questions. Would you have any questions for our speakers? Okay, I'll start the ball rolling. Maybe I can ask Dr. Nieto to tell us something about if you had started to do SBAR during your mortality and morbidity conferences. How do you think this has improved, and what have you done with? Has this improved outcomes, or has this changed any way you've practiced in the Department of Anesthesiology?
Actually, in the beginning, it was difficult to start SBAR. Our residents would have a hard time organizing the information in such a way that there would be a logical outcome. And so once we had fixed that, and we had more success in instituting the SBAR during the conferences, we found certain lapses in the process by which service patients are treated. You're not supposed to treat them differently, but however, due to cost of care in our institution, they are treated differently. And so we caught, for example, we had a patient for ERCP who was poorly evaluated, and immediately the procedure started, and the outcome was terrible. The patient expired. And when we looked back on the case, we found out that there was no cardiac evaluation. The patient was a end-stage renal disease patient, and there was no workup done prior to the ERCP, or there was no temporization of the patient's condition. So we instituted policies to govern pre-op management. And so that was one of the outcomes of our SBAR morbidity mortality conference. Immediately, our chairman